Are you someone who's been struggling with low back pain, but the problem is when you get to your provider's office, you can't seem to recreate that symptom? Palpation is key when finding chronic pain problems. You don't necessarily need a provocative test to find where adhesions are pinning down nerves or restricting range of motion. In this video, you're gonna see our friend Mike. He's been experiencing chronic pain in his low back when he's laying in bed or sitting up in bed, but we can't seem to recreate the symptom using our provocative tests in the office. Because Dr. Stepien is such an experienced adhesion release methods provider, he knows that palpation is the key to finding those adhesions. Adhesion release methods can teach providers how to find those adhesions through palpation, and that you don't necessarily need to light the patient up with a provocative test in order to have an effective treatment.
A tightness in the morning when I roll out of bed, and there are some times when I am sitting on the bed, like at night watching TV or sports or something, and I go to roll out and get up and do whatever, that tightness appears. I would say it's like a 6.
And then how about in the morning?
It's like a 6.
Okay.
There's nothing you can do to make your low back hurt.
No, there is nothing, unless I just have to sit for a while, I
Sit back
guess.
a little more. So then we just go into palpation mode. And first we just scan, and I'm seeing what is hypertonic.
When we use terms like hypertonicity in these treatments, what we're saying is that the area of soft tissue that's being palpated is very, very tense. And the reason that that happens is because there's some sort of injury or stress or nerve issue where the muscle is essentially tensing around it in order to protect it. If the muscle is that tense that we can't kind of palpate our way in there, what that means is that we don't have access. Access is one of the most important things to treat adhesion because you need to be able to feel that under your fingers. And so if an area is hypertonic, you can't feel the adhesion in your fingers, and thus you may need to treat another area or at least palpate another area to try to find other adhesions that may help to loosen that area up, and thus you can get access into that spot.
His iliacus isn't great, actually. So I'm down going this way into iliacus.
The iliacus muscle is a deep hip flexor muscle that sits in the bowl of the pelvis in the iliac fossa, which is sort of that like curved surface of the hip bone. It joins together with the psoas major and forms the iliopsoas, which is one of the strongest hip flexors in the body. You have tension or adhesion in there, you are going to feel it in your hips and in your back.
Feels like it's under the lateral femoral cutaneous nerve.
The lateral femoral cutaneous nerve is a really important nerve that starts in the lumbar spine around the L2, L3 nerve root. It runs through the pelvis and then near or kind of under the inguinal ligament and then down the thigh. If this is being entrapped by adhesion, this is going to cause pain in your low back, your hip, your glute, your leg, your foot. This one is really important.
LFCN goes this way. Let's see. Iliohypogastric is over LFCN like this. So you can often get adhesions right in that corner here, which sounds like or feels like that's what he's got going on. Go ahead.
The iliohypogastric nerve is a nerve that starts off in the upper lumbar spine around like the L1 nerve root and then travels kind of through the abdomen. If, as Chris says, those nerves are kind of crossing over each other, and if there's a spot of adhesion that's gunking them up together, yeah, you're gonna wind up with chronic pain.
Whichever direction the adhesion pulls. So you can feel if the adhesion's going up this way and I take tension going that way, it'll just won't tug. And then until I go, and you can feel when you go in one direction that if you get closer to that direction, it'll start to tug more. And then if you go right up in that direction and you tug on it, then it's going to, you're gonna feel the fibers, the spider webbing on that angle pull.
Let's talk about tension. So in adhesion release methods, we have this idea called tension clocking. And what that means is sort of the direction that we are applying tension to an adhesion. If we're doing it this way, it's 11 o'clock. If we're doing it this way, it's 6 o'clock. When we are pinning adhesion down with our finger and then creating the tension with the body movement, as you can see here, Kate is pulling the leg back as Dr. Chris applies tension up towards the ceiling. So what he's doing is he's actually curving his fingers in and pushing up. And the reason for that is because as he's palpating around, he's feeling for where the muscle is pulling the most whenever he applies tension in any direction. So if he feels that the biggest pull or the biggest tension is happening when he goes up, that's the way he's going to apply the pressure. Then as he holds the adhesion in with that tension and Kate moves that leg, it's actually tearing the adhesion under his fingers and loosening up that muscle or freeing that nerve.
He's got some type of anomaly where one of his abdominal nerves is going straight up and down.
So this happens from time to time. You get a patient that has sort of an anatomical anomaly with how their nerves run. Nerves don't really run in straight lines. They often kind of carve paths through the body. They slip through muscles. And in this case, there just happens to be a nerve in Mike's belly that's running straight up and down where a nerve normally wouldn't run.
All humans have a lot of anomalies. Now it's moving better, except right there.
I gotta give it to our boy Mike. He's being a real trooper. Those nerves and muscles in the belly that affect the low back, when we're doing these kinds of treatments, they can be incredibly painful. And Mike is maintaining a pretty stoic look on his face, so good for him.
I was feeling it down into my leg.
Where?
It's like almost like over here.
Probably has some connecting branches with the femoral nerve, which go that way, because nerves connect.
Chronic low back pain isn't always about damaged discs or obvious imaging findings. Sometimes the secret to the problem is hidden in the soft tissue, and if you don't have a provider who is assessing that, especially through palpation, that is going to get missed for years, and it is going to result in you being in chronic pain for a very long time. If you or someone you know has been dealing with a problem like this, I would encourage you to click on the link in the comments below so that you can find an adhesion provider in your area and get yourself back to the life that you deserve, free of chronic low back pain.
And now I'm just on the medial side of it. Before I was on the lateral side. And I'm right against the iliac crest. So I'm right where Iliacus is on this side, the QL is on this side. I'm right in that area where they connect.
The iliac crest is the large curved part of your pelvis, so if you actually put your hand like on your hip, that's the part of it that you can actually feel. The QL is a deep low back muscle that acts as sort of like a stabilizer between your pelvis and your rib cage, so you think of it kind of like a guy line that goes between the two to keep them both stable. What we found is that the QL is just one of those muscles that is like notoriously overworked and overstressed, so if you get adhesion in there, yeah, you're gonna wind up with some back problems.
This is L304 anterior transverse. Drop the knee down. Right where the femoral trunk comes over the top of it, but I'm not on the trunk, I'm right underneath it. You want the tissue to feel soft because that implies there's no trigger point hypertonicity being caused by those nerve entrapments. And then that will pull less on his low back and his disc. Because that morning symptom's coming from his spine. It's joint degeneration. So the question is how do we unload the spine and the joint?
The transverse abdominis sits behind the rectus abdominis, which is your six-pack, if you happen to have one. I have more of a, looks like a keg. And it also sits underneath your obliques. It sort of wraps around, sits like a corset around your body, or like a weight belt.
Right now I'm where the nerve comes out of the frame and medial and deep to the psoas. Good. To get to that, the vertebrae here. So once I feel the bone, I just go lateral to it, and then I take tension towards the foramen or the hole where the nerve comes out.
So the foramen is basically just like a hole in the bone that allows structures to pass through, so adhesion around that area, nerve can actually get stuck inside of there. So we're gonna go through the checklist of where Dr. Chris found adhesion and how bad it was, so that we have an idea of what we've treated. So the next time Mike comes in, we know what we've addressed already, what kind of improvement that's gotten, once he comes back in and tells us how he's been doing after a few days.
Left L3 nerve root medial psoas, moderate. Left L304 AIT, moderate. Lumbar plexus iliacus, 3 passes, severe, and iliacus was moderate to severe.
You know, I know it's difficult when there's no symptom present, and I'm pleased that you just going hunting there.
We don't need a symptom. Our palpation's the gold standard.
If you want to see more about how adhesion release methods can treat sciatic nerve pain, check out this video.